some people will be late
Yeah, sure.
joining, so
Yep.
we'll just keep track of that for you. So we will get started, and I will hand over to you both to do your thing.
Good. Well, the first session, I'm going to briefly review the value story, and then get feedback, I hope, from people if they've managed to get any work started on value or on waste, or if they've tried to introduce the value word in the local environment. So I'm going to just go quickly through the value story again, and then hear back from you. But you can start putting things in the chat room if you can, about things steps you've taken to reduce waste and increase value. So let me share here. So here's the standard pitch. Just going through it, which, as I said, this would be, I think we sent this to you too. I don't know if any of you have managed to use it in all or in part, but ladies and gentlemen of the health centre or the town hall or the hospital, need and demand are going up faster than resources. And resources are not only money, but staff and time, carbon and money. So here are the causes of increasing need and demand. And we've made some changes here that I'm going to share and see if anyone would like to join. Firstly, population aging. And actually, on Thursday of this week, I'm launching my new book called Increase Your Brain Ability, Reduce the Risk of Dementia, based on this model of what's happening to us if we live longer. That aging by itself is not a cause of major problems until the late 90s. The problems are loss of fitness, physical and mental, disease, and social and environmental factors. What's really emerged in the last couple of months has been the changing understanding of disease. And this is a paper I shared, which I think is a very important paper, because I think health services are spending a very large amount of money on polygenic screening. And of course, you can walk into Boots and places and buy screening, and then expect the health service to pick up the follow-up. And this is Nick Wald, who was in Oxford, now in London, still lives down the road. And they said, well, polygenic screening, genes for common diseases, maybe 5 to 10%. The other 80 to 90% are the environmental issues, social and technical. And of course, by this we mean environment back to birth. And some people would even claim before birth. You think about the environment affecting the cells. Now, this is not denying that cells have genes and that cells are important, but it's just getting for common diseases, it's getting the relative risk right. For example, my grandparents died at age 64, but that hasn't worried me, because I think the main reason they died at age 64 was being poor in Scotland 80 years ago. So I never saw a grandparent. But that's not genomics. In England, I don't know what's happening in Wales, but in England, huge amounts of resource are going into polygenic screening, which we haven't managed to stop yet. And I think this is the word that I introduced. This is the exposome. And this word is now appearing in the big shot publications like Nature Medicine, exposome. So you've got your chromosome, which contains your genes, and your exposome. And this is the this is the shop of the John Radcliffe Hospital in Oxford. I actually fell out very badly with the Duchess of Marlborough about 40 years ago. I was going to speak to the League of Friends at the Nuffield Orthopaedic Centre to their annual meeting, and she was the chair of the League of Friends, the Duchess of Marlborough. And as I walked into the Nuffield Orthopaedic Centre, I just popped into the shop to buy something, and there were cigarettes on sale. So I opened my talk to the League of Friends of the Nuffield with the need to take cigarettes out of their League of Friends shop, to be met by horrified looks because cigarettes were their #1 source of income. So this is called the exposome. Now, what we're doing is, since the last meeting, we've launched a major system called Live Longer Better. And if any of you are interested in population aging, I'd be very pleased to share this with you. Interestingly, this is not what's emerging. I think, as I think it said last time, I'm seeing the end of 2 love affairs. One is the love affair with the gene, and the second is the love affair with health services. Health services are disease services, very important, but as Anant will cover in a later session, we need to think differently about how we develop services for well-being and for prevention by working in the with communities, and not just in the community, but with communities. So here in England, we're working through what are called neighbourhoods, 100,000, no bureaucracy, just getting them to get together and get older people involved and get older people doing more to help other older people and to help younger people. And this is partly in my book about reducing your risk of dementia. Volunteering is a very good way of reducing your risk of dementia. And getting on the committee of a volunteer organisation is even better. The arguments and challenges are good. So, population aging. Secondly, and we looked at I still haven't taken any action on my MGUS. This is a letter to me from a blood test that was taken. My light chain ratio is mildly out with the normal. These abnormalities anyway, so I haven't done anything about that. But I'm pleased to say that since we last met, I can say that I have been through liver screening, renal screening, and thyroid screening, and all are negative. Well, we've never approved liver screening, thyroid screening, and kidney screening. This was just a blood sample they sent in for cholesterol. I don't know if I even needed my cholesterol measured, but as a silent shopper, it was quite interesting to see what was happening. So here we have 3 new screening programs that have been nowhere near the National Screening Committee. Why my magnesium was mentioned, I'm not sure. But maybe there's a magnesium deficiency syndrome I'm unaware of that some enthusiastic biochemist has discovered and written an article on and added it to the tests in the John Radcliffe. I have actually done a bit more silent shopping since we last met. I tripped over at home, so I was completely sober, but tripped over at home and fractured my neck of femur 8 weeks ago. So I got up and I could stand, so I wasn't too worried. But I went out to a party and sat at dinner. But it was pretty painful by the end of the dinner. So the next morning I went to the John Radcliffe and had a hip x-ray, which was negative. But the CT scan, is an interesting bit of technology, was positive. There was a clear crack across the neck. So I've got 3 screws into my right hip. The follow-up was actually post-discharge was very poorly organised. But I only stayed in 50 hours. I got out after 2 days. 6 weeks hopping and 2 weeks partial weight bearing. And now I also got involved in a very interesting argument between the geriatricians who, and I fully praise them for this, stopped 4 of my drugs for heart disease. That was all right when I was sitting, but when I started walking again, I went into acute heart failure. But just had that dealt with as a day case. So I'm caught at the moment between the cardiologists and the geriatricians. Quite an interesting battle in terms of their relative professional values about risk and benefit. So, new technology. And here's Medtronic's new technology. And these wonderful advertisements I've found that on doors in the John Radcliffe, 1 in 2 people have heart valve disease. Did you know that? If you get breathless at all, it's heart valve disease. I thought it was lots of fitness, but there we are. Obviously, I've got that wrong. So why they stuck it in the door of the men's toilet, I'm not sure. Must have been just somebody got it in there. The other one's in a lift. I think someone got into a lift with a little kit and just stuck it on the wall. So new technology. And then, as we said, the relentless increase in the volume and intensity. So these obviously overlap. So just to summarize, we need to continue with the paradigms that have gone before, all of which are very important. But we need to recognize that we have unwanted variation. And I don't know where Wales is with the Atlas of Variation. I think one was done a few years ago, but I'm not sure. Population-based variation. And the importance of population-based variation is that it makes people think. So here's 2 examples of 2 maps. One is cruciate ligament repair, and the other is the expenditure on MSK on the right. Now, the unwanted variation reveals 2 other problems, one of which is overuse. And I bored you last time, I'm sure, with saying this is the most important picture in medicine. This is a Vedis on a Vedic. And I would use this in Trinidad Town Hall or a health centre or whatever. And we collected from you last time examples of overuse and waste. But maybe just while I'm speaking for the next few minutes, put examples in the chat of in your population, where do you think there is overuse of waste? It could be drug prescribing, could be testing, imaging or lab testing, could even be elective operations. I think I don't know if I told you last time, but the last 2 people I've met who've had bilateral cataract operations, when I asked them what difference it made, they said not much. One of them, in fact, was told by the optician that she'd have to report him to the DVLA unless he did something about his cataract. And she then referred him to a private ophthalmologist working in partnership with the optician services. And he had both cataracts done and not much difference. Well, I said to him, you're bloody lucky, because there are side effects to cataract operations, so it could have been worse. So just thinking of what would be in the right, to the right of the arrow in your population. That's the first problem revealed by unwanted variation. And this means we need to make all data population-based as well as patient-based. And then the second problem needed that's revealed and the action needed is inequity. And this is still a major problem in England and will continue for, I'm sure, but inequity. The poorest people getting least healthcare. And we'll be coming to poverty later in Anant's session, where we're going to look much more at a broader approach to value-based healthcare, where we're thinking about people in the NHS starting to think about poverty and deprivation in their populations. Firstly, because it increases demand, and or first equal, because it's a huge problem, and also may increase or decrease demand appropriately. Then we come to the definition of value, and the 4 different types of value we went through last time: personal, allocative, technical, and social. And Alex Hicks, I don't think Alex is on the call, but Alex is a former dragon who's now in the, I still call the Welsh office, I'm not sure what the correct term is, and he's been given responsibility for developing value-based healthcare. And that way start to look at the allocation of resources as well as their use. So to introduce value-based healthcare, here are the 5 steps. Number 1, a population-based approach, moving from 2-dimensional healthcare to 3-dimensional healthcare. As I said to you, I'm sure as I bored you on many occasions, this is a bit like if you were young supermarket managers. Some of you would be in finance, some would be in procurement. But if you were in a supermarket, you'd be thinking about meat, fish, veg. What's the size of the aisles? And within the meat aisle, what's the right balance of frontage between beef, pork, lamb? And it'd be different in one part of Wales than another. So really focusing on the needs of the population as the 3rd dimension. This is called population healthcare. And this would mean you're starting to look at healthcare and budgets in this way. So if we take COPD as a problem, then, and we want to have more resources, well, the sort of questions are, should we shift from respiratory or from gastrointestinal? But maybe we should be shifting from, should we shift from gastro to respiratory, or maybe we should go the other way. And then, if you know, and I don't think you do know in Wales, how much is spent on respiratory disease in your health board, what's the right balance between asthma, sleep apnea, and COPD? And then, within current spend in COPD, what's the right balance between these different interventions? And I said we did a project in London where we shifted money from the triple drug therapy budget. We went to double drug therapy, and that went into 2 other bits of the bureaucracy altogether: smoking cessation and rehabilitation. So number 1, think populations. Number 2, think systems. And again, I told you last time about the one of Oliver Williamson and complex adaptive systems. And the Live Longer, Better system for older people is a complex adaptive system. It's not a new bureaucracy. And value-based healthcare, we need to develop as a complex adaptive system. Value and waste are too complex for either the markets to solve the problem or for a bureaucratic organization to solve the problem. We need systems, and a system is a set of activities with a common set of objectives. It's got a high-level aim and a set of objectives. And I've been to we did discuss in the last meeting that some of you were going to look at segments of your population and think a little bit about system development. And as I pointed out last time, usually the clinicians come up with the top 5 type of objective, which is fine. But we've got to get clinicians to think of the bottom 5 objectives too, so that they feel that they're responsible for and to a population. Number 3, introduce better decision support. And some of you at the last meeting said you were looking at this. Could be for elective surgery, could be for end-of-life care. But improving decision support for the people called patients. And this is, of course, evidence-based, but the clinician and the patient have to take into account the values of the patient. And the clinician has to think about other clinical issues. These are the way in which these come together. So, some of you raised last time the issue of looking at patient decision support and how that could be improved. Then number 4, network development. As I say, what I'm seeing in England is an acceptance of the fact that the reorganization of the bureaucracies is not sufficient, and we need to think of networks. And those networks may be the networks of all the practices relating to a hospital, plus the local authorities, or there may be completely new types of network like neighbourhoods. And I know in Wales, good work's been done on that. So that's number 4. And then number 5, which will, for the latter part of the meeting, we're going to focus much more on culture and the culture of stewardship and what you've been doing to change culture or measure culture, including the role of artifacts. So, to summarize, this is the evolution that's taken place over the last 50 years. And just finish again by asking if any of you have been done work on carbon reduction since we last met, because we find that motivates clinicians much more than discussions about finance. So, to summarize, that's what we did in the last big session. And at the end of that, I think we made resources available to you. And I know you're very busy. I mean, you're very busy in your day job and your course, but we're very interested to know if any of you have taken any action, either to increase the use of the word value, or even more important, waste. And perhaps people could put in the carbon, put waste in carbon. So perhaps people could put in the chat room anything that they've done, no matter how small, since the last meeting. Abby, how would that be? I've got 10 minutes to do that.
Yeah, so that's absolutely fine.
Okay, so let's see here from the back from the group as to any work that's been done on value, waste, and the population approach. Anyone like to put their hand up, or?
Or use the chat, guys. And who was my hand up? Who?
Yeah, I was. It was really inspiring the last time you talked to us, Muir, and I took a lot of the sort of learnings from this on board, and I was lucky enough to be able to present for the Clinical Service Pathways program, which is around how we're trying to reshape our services within Cardiff and the Vale. So I used a lot of your teachings from here in trying to promote a movement from a more reactive healthcare system to a more nurturing one, I suppose, where we nurture health in the communities rather than being quite so reactive. So yeah, it was really it's been really useful.
Well, that's very good, and you can use our resources, and you don't need to give any acknowledgement of where they've come from. I've got a new degree since we last met, so you may want to mention that. Muir grade TOB, that old bastard, is he still banging on about value? So you don't need to worry about that. But tell us a bit more about the group you spoke to, Hugh.
So I wasn't quite prepared for the scale of which it was going to be at, but it was basically across the whole health board. So we had the exec leads, we had all the service leads. There's about, I think, about between 200 and 250
My
people
God.
in the room. Yeah. I was expecting about 80, so it was a bit of a shock to me.
Yes. And did you spot any likely lads and lasses in the group? Usually you wait for someone to come forward and start off with one keen person or two or three keen people.
Yeah, so I had a good chat with the health board chair after, which was quite good, and she said that the presentation went down well, so it was good. So
good. And
I've been invited back to sort of help with the facilitating of some of the group work that we've done as well. So I'm thinking about how we can move stuff forwards as well, and I'm part of the community by design work as well, which is moving forwards around like you're talking about the neighbourhoods and stuff like that as well.
Yeah, the key thing is to spot an exploitee. I'm very good at spotting exploitees. An exploitee is someone who's very busy, but you can get some more work out of them. Maybe a dermatologist or a respiratory physician or whatever, but get one or two going. Yes, Helen.
Yeah, thank you. And likewise, I just found your presentation before absolutely inspirational, and it's caused lots of reflection and thoughts, and I guess you know, trying to anchor those discussions, because I think it is quite challenging to bring that sort of value-based healthcare into discussions about finance. I mean, I'm always chipping away at it, but I guess I just and you know, for me, value is the currency rather than the pound, but it's very difficult to persuade people sometimes of that. And I just wanted to share one of the initiatives that I've been involved in, which is about the development of a community spirometry service within Cardiff and Vale. So with the NACAP audit, it was noted that there was likely to be 25% misdiagnosis of COPD and 33% misdiagnosis of asthma in patients. So we sort of started 3 years ago on a spend to save about developing community spirometry to aid diagnosis in both asthma and COPD. And the preliminary, we're still looking at the data, but what we have found is that there has been a reduction in inhaler prescribing, better coding of asthma and COPD in general practice, a reduction in acute exacerbations presenting to the ED, and I guess on the back of that, a reduction in the green, you know, the waste really for inhaler prescribing, which is, you know, part of the green agenda as well. So we're pulling together the data, but it has been quite challenging to put that. So we've now got buy-in from the health board, but it was quite challenging. And the way we did it really was on that value-based healthcare lens, and the impact it had on the whole healthcare system. So, yeah, it's been challenging, but it's been really good to see the results.
Well, here we did discuss last time, Abby, the idea of a casebook, and I think, Helen, if we could send you a simple casebook outline, what was the problem, what do you do about it, why did you do it, what was the result, what did you learn? As simple as that. Again, we hope that more of you could do that. In asthma, was it overdiagnosis or underdiagnosis that you were worried about?
Misdiagnosis. I think that was the that's where it came from, misdiagnosis. So whether it could have been COPD, of course, there will be some that are missed as well. So, but we're definitely seeing we know that those diagnoses are probably more, the quality of them is probably better. So at the end of the day, the patient is getting a better diagnosis as well.
Were children included?
No, it's just for over 18s.
Okay, fine.
Yeah.
Because I'm very interested in asthma in children. I'm rewriting, well, I'm not rewriting it, but I'm working with 3 very good people who are rewriting a book I wrote 40 years ago called Football Injuries. And they run the local football club. One's a doctor, one's a physio, one's an osteopath. And I said, you're running a health service. You've got 848 kids coming every Saturday and Sunday. And these kids are on, you know, psychology waiting lists and all sorts of issues. But you turn up at the football club or the rugby club, and here's your jersey, here's the rules, right? Where are we going next week? So we're calling this the Football Health Service. And Anant will cover this later on, but you know, if you looked at prescribing for asthma in children, they're saving there. And these voluntary groups, you know, we're looking at £100 million budgets. But if you gave these people £5,000, they think, my God, £5,000, wonderful. So maybe think a little bit about, I'm pretty sure there's overdiagnosis and overtreatment of asthma. That's great, Helen. We'll write that up. Tim.
I'm completing the cliche of being a clinician that's bothered about carbon.
Yes, good.
And we, in our emergency department in the Circle of Trust, it's a bit embarrassing that we still send letters to GPs on every discharge. Also we print out a piece of paper for every patient that arrives that we may or may not write on.
Yes.
So that's about 1,000 GP letters a day and 300 printed cards. So we've managed to engage with IT to see if we can send them digitally, which blew people's minds. And then as far as printing cards every day, it's very much in the, this is what we've always done. What happens if we lose the cards? How will we know which is the next patient? But we've managed to get rid of we've got rid of the racks where we used to put the cards for the next patient. And the next step after Easter is we're going to stop printing them. So it's really, really basic, but then that's about 1,300 pieces of paper a day and letters. So yeah, baby steps.
See if you can mock it up with what it looks like for a year. I mean, by mock it up, I mean think how much it is for a year. Also, I'm still very interested in what actually goes on the bits of paper following my hip replacement, my hip fracture. That I still haven't had a single word from the NHS in Oxfordshire about diet or exercise 12 years after my myocardial infarction. I've had numerous letters about car parking and telephone numbers and that sort of thing, but not one word. That's good. Let's have a war on paper. Digital exclusion is still a big issue, of course, but again, we're looking in preventing dementia at how we can get more older people online. And I've been to any of you interested in population aging. So if you were in a care home in Swansea and you came from Gujarat, or if you loved Wagner, no one else in the care home would have heard of Gujarat or Wagner, but we're building digital communities of people in that way. So it's thinking of different ways we do it. Good. Let's have a war on paper. Symbolically, very good. Claire. Oh, sorry, it's Chris next. I got the numbers wrong.
Yeah, no, thank you, Muir, and thanks for your input. I suppose coming from a slightly different profession, so some of us are from social work, and I think the values base, might lend itself, I suppose, better to us that come from a less technical expertise. Being grounded in notions of justice and dignity and all of these things, rights and fairness, and I think what particularly resonated was the kind of, we're having a big push now. I can see Kelly's with us today from Pembrokeshire, so we're having a big push to really strip our system from waste. So I do think, in terms of need, I don't see children's services need being driven by real need. I think our systems and demand are very much being driven by system generated waste, which you talk to, and I think we're finding ourselves going back to the relational element of practice, which is seemingly far more effective in working with individuals through their day-to-day problems, and indeed identifying solutions with them, as opposed to thinking we can do for them, because we do work in a system, and I speak only for children's services, that seems to have become overly paper-based in terms of how we see people, as opposed to seeing them in real time.
Yeah, an interesting cultural issue I'm discussing with Live Longer Better is the word care, which by and large means doing things for people. And I'm saying, no, that just accelerates their decline.
Absolutely.
So why don't we call carers enablers? I haven't succeeded in that yet, but that's, and probably never will succeed in that yet, but never will succeed in that. But social care, there's lots of fascinating issues with that needs a revolution in thinking in the way you're doing. Claire.
Hi, yeah, so we've introduced a national prescribing indicator, so all GP practices and health boards are monitored on this. So pushing a switch from some antibiotics used for respiratory tract infection, so moving from 7-day prescription course to a 5-day prescription course. Obviously the evidence is that 5 days is adequate, so having a positive impact on antimicrobial stewardship there, reduction in carbon as well.
Great.
Since introduced it, some health boards have gone from a sort of 40% use of 5-day courses to 80% now, so that's had a really big impact.
Well, let's capture some of these things, Abby, because it's helpful for marketing the Dragon, the course. So we'll circulate it. It's a very the idea of a casebook, I think, is of course Sherlock Holmes is. I pass it when we go to London by Marylebone, and then we're very near Sherlock Holmes. But the idea of a casebook, not a 4-page article in some journal that no one will read, but one side of A4 I gave evidence at the House of Commons Committee on population ageing and aging well and physical activity. And I said to the committee, yes, we're using AI and we're using A4. And the MPs all looked at me, A4, what do you mean A4? But then the penny dropped. So we'll do something on A4. Okay, that's very good. Anything else anyone would like to add? Claire, can you now provide, what have you got? Is this Wales prescribing? All Wales?
Yeah, primary care across Wales, yeah.
Yes. And is there an atlas of variation, population-based?
Sadly, there isn't. The data that we have in Wales is not as good as what they have in England, unfortunately. We're a bit hamstrung by the availability of the data. So we do the best with what we've got, but it's not great.
What's wrong with the data?
We just don't have we can't interrogate it in the same way as you can in England. So we can't link up, you know, we can't make a picture of what a patient has had in 12 months in a way. It's just really basic data. Hoping that'll change, but not anytime soon.
Yes, I'm going to meet the Bennett Institute later in Oxford.
Oh, very jealous of what they've got access to. Yeah.
Yes, yeah. Okay, so the value-based healthcare you've tried, it's gone down reasonably well. Anyone else like to make a comment as to? Kristen.
Hi, Muir. Just on as another example, I'm working with TNO and interventional radiology at the moment on a procedure. That's a IR procedure that probably takes about an hour for lateral hip pain, and that's using instead of surgery in most cases. So, so they go through various pathways, but a lot end up with surgery. So. Obviously there's a lot of different outcome measurements to it, so I think there's something like 7 outcome measurements that we're looking at, which is mobility as well as the different pain and neuropathic pain. So the first pilot is starting in 2 weeks' time, so got a pilot of about 30 patients to see how well it works. So if assuming that it will work well and the outcome measurement works well, there's different areas that it can be worked on as well.
That's very interesting. Yes, so I've had the full blizzard of DEXA scan and but in a sense, so why am I having a DEXA scan? Well, you might have osteoporosis. I said, well, of course, everyone's got a bit of osteoporosis, but why do I need a DEXA scan? So I had to turn up on a Sunday morning with staff brought in and paid. I don't know whether they were paid extra money, but this is the North Orthopedic Centre. So I think I've had every type of image around my hip. It's quite interesting. I'm pleased to say, involved in a randomized controlled trial, and I think I got screws. I get 3 screws as opposed to a joint replacement as part of the randomized controlled trial. And I told them, Sir Ian Chalmers, who used to work in Cardiff and then came to Oxford to set up the Cochrane Centre, or the National Perinatal Epidemiology Unit to start with. He's got a card in his wallet saying, in event of serious injury or illness, please enter me into any randomized controlled trials that are available. Because in general, services that have got a randomized controlled trial are better organized and have better outcomes. So I think I got my screws as a result of a, but that is very good, the screws, because my scar is 1 inch long. There's no plate down the side of the femur as there used to be in the old days. Anant, how are you getting on?
It's moving again, so I should be stationary imminently. I don't know if anybody else has any comments. Otherwise, do you have my slides, Muir? Oh, yeah, Emily.
Oh, Emily.
I can talk for a little bit. So yeah, sounds like a lot of people here after your session. I was really motivated to go and do something different. So a lot of my work is around patient flow, and actually I've used that exact image in all different arenas, whether it's presenting at board, whether it's on the shop floor with staff, and it's been really pivotal. And we've moved very much into the values-based healthcare space, because I actually didn't quite realise that is where I should have been all along. Bryn prompted a little bit of discussion with our values-based healthcare team, but after meeting with you, it's really interesting. And actually, I've tried to, so I basically try and reduce waste by helping people understand that patient flow is not about increasing bed capacity, it's about time. Professor Dolan does a lot of masterclasses and a lot of work around deconditioning, but it's about reducing waste by putting the patient's experience at the centre of healthcare. And obviously we look at all different types of metrics in healthcare, length of stay and blah, 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 but actually we're not looking at what the patient determines to be the best outcome. Yes. So we've worked out, I've done lots of process mapping of the patient journey to look at the difference, like the as is and to be, what could happen if we looked at the quality and timeliness of our decisions and made them less fragmented. So doctors, then therapies, then discharge, and try to bosh them all together. I've asked for support around finance and doing some kind of impact assessment. We increased weekly discharges at site level by 54%, and I've begged people to help me quantify that, because everybody just wants to know what the cash conversion is, and everyone's really resistant to do it. So I just grappled with like parliamentary websites and tried to do it myself, and I had a spend avoidance total of £7.2 million in just the one district general hospital. So I boshed it onto my business case, knowing that I'm definitely not an expert, and there probably will be all different variables that should be considered to see what would happen when I presented it to the executive team. And actually, there are obviously some things we need to take into account, and 15% reduction for like readmission rates and all that kind of stuff. But it actually got people talking. And so that's still being spoken about now, which is fascinating. But it's kind of catapulted us into a different type of space where people are actually looking at, okay, spend avoidance. There's resistance because obviously finances at the moment are really tricky, and people are saying, well, that's not tangible cash, you know, we're not getting like cash in our hands. And it's so frustrating because it could be, it's not just spend avoidance for us as within the health board, but it's days lost for patients. And it baffles me that that isn't kind of hitting where it should be at that really senior level. So yeah, so that's been one thing that's been really fascinating. But also we then flipped a lot of our so obviously we get loads of data, we've got loads of digital dashboards and stuff like that. We started interviewing patients and staff and relatives, and this is where I talk about what outcomes actually matter to patients, or what do we presume are the best outcomes. And some of the stuff they gave us was absolute gold, and I've started like dropping those into my program reports, or you know, those actual quotes from patients to try and relatives. So yeah, it's been really interesting, and this has really helped me consider how I can change my message, basically. So yeah, thanks.
Terrific. This number of 7.2 million, where did that come from?
So it's an increase. Our outcome measure was weekly discharges. So we increased weekly discharges by 54%, and that was across 10 unscheduled care wards.
Yes.
Now, the average length of stay for our health board in January was 10.2.
Yep.
So yeah, so we did it on a weekly basis of how much. So weekly basis, you multiply it by, you take the whole length of stay.
Yes.
So it would be avoiding a whole length of stay, basically. We did it on a weekly basis. And then obviously on an annual basis, if we continue to see that sustained improvement. But we've had that sustained improvement since October, which is when we intervened. So it's continued to rise. But it's so tricky within healthcare. So it's called, it's 6 goals is what we've been working on. And one of those goals, and I've never quite pushed our improvement to be just based on what my programme is. Always shared that to say, look, we're all working on different parts of the system, but I think that doesn't not all people are exactly like the same, and they quite like to hold on to the data, like you talked about that data bias. So this is my improvement, etc., etc. And I've realised that's not how I can do that. My values don't work like that. I can't say I'm responsible solely for this. So I've used it as a bit of a marketing ploy to go, okay, my figures might not be exactly right. We've got to take readmissions out of that, but look at what's happening, look at the shift, and look at what we could do. So I'm working with finance and our digital team to look at how we go forward by measuring this, but on a live basis, so we can look at spend avoidance as an actual metric.
Good, that's great. They're just looking at see if there's anything more good points, and we'll capture what's in the chat. We need to review medication, waiting lists, and children. Anant will cover a bit of that in terms of taking a broader view to health and what's happening outside the National Health Service. I'm talking a lot more about the National Disease Service. And this issue of well-being is coming up a lot. Remember, the WHO definition of health, it's complete physical, social, and mental well-being, and not merely, to quote them, the absence of disease or infirmity. So what we are doing with our work, mostly with older people, is saying there's a well-being deficiency epidemic, and the NHS is not equipped to deal with well-being problems. So we respond by giving antidepressants. Is it 7 million people on antidepressants in the UK at the moment? Or we refer them for some inappropriate investigations. Or they turn up at A&E, with well-being problems, and that we don't have a response to that. Hugh?
Yeah, we've done a bit of work on this as well around. We get a lot of people coming into. I'm a physiotherapist by background, and we used to get a lot of people coming into physio with back pain or chronic pain, and it was very much a case of, the old way would be like, we can do this, we can do some exercises, but there was never really any conversations around what might be the other things that are going on within that person, sort of like the biopsychosocial model, I suppose.
Yes.
So we've put in a few programs. Post-pandemic, we had a bit of a massive reset of what we were doing, and we've really sort of like invested into motivational interviewing, compassionate conversations for our staff, and sort of the Bridges self-management training as well. So we put a package together to try to change the culture, I suppose, around what we're doing within our departments, to have more open conversations with people and to actually find out what it is that they actually are looking for. And we've seen a massive turnaround in sort of our civic data. So in 2019, I think, when we did some of the looked at some of the questions around, do you feel included in your in the decisions made around your care? I think at that point we were scoring around 65%. And when we looked at the 2025 data, once I've gone back and since we've put these programs in place, we were up to nearly 80% of people felt that they'd been included in the decisions around their own care. We'd had a 10-point increase in the number of people who understood, or they felt that they were able to take on the information that was being shared with them. So we've seen a big sort of cultural shift in terms of how our staff are interacting with people, so that we're actually able to have those conversations with people around weight management, smoking, drinking, exercise, all of those things that maybe we might have avoided before because they were difficult conversations.
Right.
So now that we're doing that, we're finding that we're getting better outcomes for people, and that's what people report, and they're feeling listened to. They're feeling as if they're actually getting what they want from the service that we're doing. So hopefully we're going to be presenting that at some point soon as well, to show that, if you change the way in which you have that conversation with people and you understand what it is they want, you get the outcomes that they want, and it also has an impact on what you're doing in your service.
Yeah, well, that's the outcomes approach, and also the group approach, this the community approach, and this is what we're looking at with older people. And I'm sure the rugby clubs in Wales have an important part to play already in this for men. Women aren't. Women are often much better organised in community than men. I sometimes say we need to think about a group called MEN as a problem group, but I think even now we're starting to see different approaches being taken that are focused on well-being. And there are, I don't know if there's an agreed measurement for well-being in Wales, but the Office of National Statistics is a very good means of measuring well-being. The simplest thing is to ask people how they feel on a score from 0 to 10. And the main determinants of well-being, interestingly, if you were to promote something to improve well-being, is getting involved with other people to do something to help other people. I did think once of setting up a shadow ministry in London that would issue planning applications for sewage farms, radiation disposal units, and other dreadful things, because that would bring people out of their homes to meetings in village halls and town halls to feel they were doing something with others. So this interesting issue about volunteering and getting people involved, I think is something that's emerging now in the new paradigm of having a health service that is specific focus on well-being as well as on disease. Now it's 9:55. I certainly have to stand for 5 minutes and move about a bit. Anant, how are you?
I'm fine. I'm stationary. Can you hear me okay?
Shall I suggest we take 3 minutes on the move, Anant, and then people...
If I maybe do my slides first, because then I can get to
right.
I can get to the next station. So because actually a lot of what we were discussing has already been covered. So I think I can be like 2-3 minutes, and then we can take a break and then go into the group work and then come back for feedback. Does that work?
Yes, I should say Anant's on his way to Brussels. Anant's a big shot in Europe on food policy.
I'm not a big shot.
You're a big shot, Anant. That's the other half of his life. But Anant doesn't only do things at sort of European Union level. He's working with school children in East Oxford, which is the poorest part of Oxford, to get them more engaged with the local green environment. That's right, Anant, isn't it? You've got a school involved in...
Yeah, we work with a group of schools and just very basic things, getting them more physically active. And in secondary schools in Oxford, we can no longer afford PE teachers, so it's pretty bonkers how much money, going back to some of Muir's slides, we spend on these genomic tests and imaging and things like this, but we're not getting the basics right. There's an entire generation that's I think going to have some quite significant health issues going forward, just because we're not doing the right things. And it's outside of the healthcare system. Muir, do you have my slides?
No, I don't. Do I?
Oh. I emailed them to you yesterday, just in light of the fact that I was on the move today.
Yep, wait a minute then. You were. I'm opening.
Okay.
Yep.
Super. We don't. We can skip the population health one. So again, I think we'll just. Yeah.
Let me just make sure I've got this up now.
Super. I think we can skip to already to slide 9, because we've gone through the population healthcare stuff, and actually what the Welsh colleagues are doing is super impressive. Actually, can we go to slide 9?
How's that?
So yeah, perfect. So this was a paper published last year by one of our colleagues, and they looked at all of the new drugs that were introduced into the NHS from 2000 to 2020. And in the NHS, we spent 75 billion pounds on these drugs. And their question was a fairly basic, fundamental one. Would we have, compared to the QALYs, population level QALYs that we got from those new drugs, what would have happened if we spent that 75 billion on alternative uses? And they still stayed constrained within the realm of healthcare. So that 75 billion still just stayed within healthcare. But what they found was that spending on those new drugs, that 75 billion pounds, meant that we actually lost 1.25 million QALYs in the population. My suspicion is that if we spent that money on alternative purposes, even outside of the NHS, for example, school meals, green spaces, community centers, leisure centers, we could have gained even more QALYs within the population. And if you looked longitudinally over time, we could have done a lot more primary prevention stuff that would, prevent disease in 5, 10, 15 years time. Next slide. I think that touches on some of the spend avoidance, not getting enamored by the shiny new drugs and diagnostics and tests, etc., and exercising quite rigorous judgment in terms of what's introduced into the care pathways. But in addition to that, a QALY is a quality adjusted life year. It's a standard measure of kind of health outcomes. We can send some references on this if helpful. So the the slides will be shared. That's one side, which I think sort of touches on one of the comments made on spend avoidance. These shiny new things, exercising very robust and rigorous judgment before introducing them into care pathways. But the other is just the waste within care pathways, which I think you guys have, super impressive what you guys have done. These are just some headline figures. In England, we spend about 2 billion pounds on drugs that are completely pointless. And that's about 10% of all drugs that are dispensed in England in primary care. And we also know that 40 to 50% of patients with chronic conditions don't take their meds. So that's another 5 to 8 billion pounds. And that this is not even including the 75 billion pounds that we spent on the new drugs. And this OECD report that came out some years ago kind of had a rough 80-20 figure that 20% of the healthcare expenditure is wasteful or is actually suboptimal, in the sense that we could be spending it on interventions that can deliver better value for the population. Next slide. So these are figures from the NHS, and I think I presented this the last time. When I started working with Muir in 2011, we were spending 110 billion pounds. Fast forward to now, we're spending 220 billion pounds. So it's doubled. And in that span of time, life expectancy is continued to decline. Our wait list is over 6 million people. We have massive inequalities. We have a very demoralized and burnt out staff. So, there's a fundamental question as to what we're actually getting for all of that taxpayer finite societal resource that we're investing into the NHS. And this was actually published in the Telegraph. Muir shared it with us. Lord Bethel, the headline in the Telegraph was "Doubling Cash for NHS Had No Impact on Health." And it's actually a really good article. It goes through some of the details. And this only came out like 3 weeks ago. We've been ranting about this for a while, but I think this is kind of case in point in terms of more money in the NHS is not necessarily the best way of improving health within the population. So that brings us to the group work. Next slide. So I think you guys have already done a lot of this in practice. So you could even take one of the examples that you cited, or you can kind of go beyond what you've already done. So the idea was in this 20 minutes that you guys get together in groups, and Abby will hopefully be able to kind of transport you into your groups. You choose one health board from your group or team and identify 3 priority areas from a population health perspective, healthcare perspective, which Muir introduced. So looking at clinically defined conditions like atrial fibrillation or type 2 diabetes, symptoms like breathlessness or knee pain, or groups with a common condition or a common characteristic like frail elderly. And then for one of them, once you've identified these 3 areas, for one of them, identify the top 5 most wasteful activities and try to estimate the resources that could be liberated by stopping that wasteful activity. Of course, this is not going to be perfect, but just kind of rough ballpark figures. I think you guys already have this in your mind. It's super impressive what you've been able to do just, since the last lecture or since the last session. So yeah, 20 minutes. And in terms of timing, Muir, do you want to do the break first and then we do this? So what, 5-minute break or 10-minute break and then 20 minutes group work, or what would you prefer to get moving?
Oh, let's just think about the others. I think an hour is long enough sitting, so we should have a break, and then we'll have another little break later on, so people can do 20 press ups or stand up from a chair 15 times or jump to conclusions. And I told you, and Aaron Bevan said the only exercise doctors get is jumping to conclusions. Okay, let's have well, what do you think, Anant? Should we?
Yeah, why don't we do, well, within the groups, maybe we can aggregate because we're running a little behind. So maybe within the groups, while they're discussing, they can do press ups and jumping jacks. If they're a little bit out of breath, that's okay.
Okay, go for it.
Shall we go for group work? And then, Abby, maybe if you could transport people into the groups and bring them back, groups of 5 to 6. Random allocation is fine, and then we can bring them back at 10:25. Does that work?
Yeah, no problem at all. Brenda's already set the groups up for us.
I will take a proper break in the middle of the morning. Yep, good. Okay, good.
Okay, but yeah, opening the rooms now. See you guys in quarter of an hour.
Thanks very much.
Oh, very good response.
Lots of good work going on, Muir.
Very good response.
Yeah, we've had lots of good work. Emily, who I was hoping she was going to share her story, found the last session very informative and has kind of used some of the practice as she discussed, which is amazing to see. And it's lovely to hear from, like Helen, etc., as well, of work that they've got ongoing.
Well, that's where if we just capture some of these things on the one side of A4, which I was like, this will help the Dragon Institute with bids for resources for next year. I mean, we've got the people really working, haven't we?
Absolutely. And if you've got a template, then we can share that then and get them to fill it in and collate all that information.
Yep, I'll get rid of that. Okay, I'm going to have a stretch.
You do that.
Oh, good.
Bless him. See you in a minute. Hey, Bryn.
How are you doing?
Good. You okay?
What time are we bringing them back? 25 past, is it?
Yeah. So 1 minute warning.
I gave them a 5-minute warning, so.
Fab. I'm just looking a second. So we've got feedback now.
Discussions. Tell us when you're ready to bring the group back, Muir. I'll close chat rooms.
Is Anant there?
I haven't seen him, and it looks like he may have dropped offline, actually.
Am I online? I can't see myself.
Yeah, we can see you and we can hear you loud and clear.
Oh, good.
But I can't see Anant on the call at all.
You sound
worry.
really quiet, Bryn.
Sorry, it's my microphone wasn't in the
That's
right
all right.
place. Yeah, I can't see Anant on the call. I don't know if he's run into a patch of bad signal or.
No, I think he's in St Pancras Station.
Okay.
Okay, let's just check in the time for the rest of the morning.
So I think.
From looking at the agenda, Muir, we've got feedback for 20 minutes now from the groups.
Yes.
Then there was a scheduled break, but I don't know if you want to push that back to later.
No, I think that'd be fine. Yep.
And then Anant to provide brief overview. That's for 10 minutes after the break, and then we break in back into group work after that.
And then I'm on for culture later on.
That's right, yeah. So after the feedback then for 20 minutes, we've got culture and stewardship from yourself at approximately 11:30 for 20 minutes, and then a 10-minute close and reflection to wrap up by 12.
Okay, fine.
Yeah, because we are running a bit behind time, aren't we? So
that's fine.
Yeah,
so,
what we could do, Bryn, is we could do feedback for 15 minutes now, and then a short break.
Yeah, let's do that.
Yeah, which would take us up then just to 1:45.
Yep, good.
Okay. Right, should we start bringing them back?
Yeah,
yes.
Great.
Did we send them all a copy of the value book?
Yeah, I sent that out last yesterday evening, no, so everybody should have that.
So the book, we sent them the book, didn't we?
The attachment you sent yesterday, is that?
No, the book, how to get better healthcare.
We had some copies. Oh, there's a feedback. We had some copies of that in the office last year, but I don't think we've received a new batch this year, Muir.
Okay, I think I'd like to send them one. In case they have problems with insomnia.
Well, if you liaise with us and send it to us in the office, we'll distribute.
Yeah. There's also our new book, which I'll speak about later, on creating the culture of stewardship. But we'll discuss that later.
God bless. Okay, so welcome back, everybody. Muir, we can see your screen if you're sharing, but we can see the Teams channel. So we can see all of our faces twice.
Stop sharing, yeah. How's that?
Yeah,
Yeah.
brilliant. So I think everybody's back. So I think next on the agenda was just feedback from the group around what your discussions, etc.
Yes. And ideas for action. So we're definitely going to have a case book, and we'll be sending out the case report formula, and be very good if it sounds to me as though many of you are doing work that's worthy of sharing. So just in the group to start off with. We're not going to put this out widely, but the idea now is that we're recording people's work and what they're doing on the ground in a very simple but systematic way. Okay, so shall we take which group is around? Which one shall we go first?
Any volunteers?
Oh, don't worry about volunteers, just pick someone.
Oh, Helen's gone.
Good,
Thanks, Helen.
I said I'd always go last, but there we go. I thought I'd better start on this one. So we had a really interesting discussion actually about. We came up with lots of things actually. So we narrowed it down to 3 because of the interests of the group. So I was with Bethany, Lewis, and Sarah. So we talked about breathlessness, so which was a bit more of an expansion of the community spirometry, and you know, I have been involved in the community breathlessness pilot. I think there's 3 across Wales. We didn't dwell too much on that.
You remember that half of people with breathlessness have got a valvular disorder of the heart and need a Medtronic implant. Did you remember that?
Yeah, that wasn't the percentage that we found. As you said, it was about fitness and obesity were the number 1 causes of breathlessness. So, you know, those discussions we'd factored in already. So, yeah. So, and then the second one was about communication, duplication of works, communication across specialties, across the interface. We talked about patient ping pong. So coming, you know, and then the third thing we talked about was preoperative assessments and patient optimization. So those are the 3 that we chose as examples of a huge amount of waste from both a workforce, financial, you know, digital and patient time waste. So I'll probably hand over to my colleagues to talk about the patient ping pong and communication, the 5 there, if that's
I
okay.
love patient ping pong. Did you invent that? I certainly am ping ponging at the moment. I can tell you between geriatrics and cardiology.
That's my term, but
between 4 drugs and 8 drugs.
Yeah, no, I don't. I've used that for years actually, but it just explains the toing and froing, and yeah. So I don't know whether Lewis, Bethany, Sarah, you're happy to talk that one through.
Yeah, I don't mind briefly talking through that one. So we were reflecting on when patients kind of straddle multiple specialities, that there's this back and forth for them without a clear communication line between those 2 specialists, which is a huge waste of the patient's time, very often the clinician's time. Whereas if we just had this kind of central point of information being stored and the ability to look at notes and have conversations, so much of that would kind of be taken out. And as part of that, there's also something in there about the culture and the ability to just pick up the phone and ask a question or have a conversation instead of this letter writing, which Helen talked about another example, but you know, letters being sent in 3 weeks until they get delivered and then read and responded to, and then it's another X amount of weeks wait, which again is all about that waste of time really for the patient.
Time, yes, and we talked last time about the burden of treatment. That's in the glossary. This concept of the burden of treatment, which we haven't really thought about before. Good. So that was good. So you focus on a symptom, a clinical segment of the population, breathless. I love the waste in patient ping pong and pre-op assessment. Did you in pre-op assessment, did you discuss the idea of asking the person what is the problem that's bothering you most, as opposed to diagnosis, or as well as the diagnosis? Because that's what we're starting to see emerging now, is that we're hip replacement is treating diagnoses, not necessarily the problem that's bothering the person most. Anant, oh good, Anant's here.
Hey, just a question, a couple of super interesting on the patient resources. The amount of societal time that the healthcare system wastes is actually incredible. And the opportunity cost of it is staggering, that I don't think we actually put a cost on. You know, if we give an anecdotal example, one of our team members, his father tweaked his back and he had an appointment at the JR. And they live in a place called Whitney. So, you know, on a no traffic day, it takes about 15 minutes, 20 minutes to get to the JR hospital, but there's never a situation where there isn't traffic. So it took them about an hour and a half to drive to the hospital, hour and a half to drive back. And then their consultant was late by about 2.5 hours. So now we're at 6 hours. And then once the consultation finished, they had to stay in the hospital to wait to get their medicines at the hospital pharmacy. And that took about 3 hours as well. So it was 9 hours, but it was 9 hours times 3 because it was the father, the daughter, and the mother. It was 27 hours of citizen time in the healthcare system's hands. The opportunity cost of healthcare system time wastage is astronomical. And Muir, poor guy, I mean, you're spending so much time, you know, going back and forth in the hospital, both you and Jackie. So that's times 2 or, you know, whatever amount of time there is.
But Anna, you're committing one of our great crimes. You're using the word system.
Yeah.
Because there is no system.
Yeah. Yeah. So just very quickly then, on this, did you pick a health board where you would want to focus? So we have breathlessness. Did you pick a health board, and then did you identify? So there's time wastage of patients, which I guess, you know, that can go under resources. And do you have an estimate of like a cash envelope that could potentially be liberated if some of the wasteful activities were disinvested from?
So I don't think we did for the patient ping pong, but I do have some data from the breathlessness, or certainly from the spirometry, which we talked about, and I've found my paper here. So the data from Wales, there's 84,000 patients on COPD and registers in national asthma. We're talking about approximately 280,000 asthmatics, and it's recognised that approximately 1/3 are incorrectly diagnosed, and 25% of the COPD patients are probably incorrectly diagnosed. Therefore, there are nearly 100,000 patients with an incorrect diagnosis across Wales, which potentially costs £20 million in inhalers. And the climate impact is 20,000 tonnes of CO2 released each year. So asthma is estimated to cost £1,340 per person per annum. And for COPD, £3,102 per person per annum. Improved measurement and interpretation could produce cost savings annually of 2.57 million, and for asthma, and 1.33 million for COPD, respectively. So that's the Wales figure from the NACAP audit. So sorry, that's not to do with the preoperative assessment, but that's to do with spirometry savings.
No, there's fantastic numbers. Do you have other, maybe, so we have inhalers, we have spirometry. Do you have any other low value activities if we were to go for a top 5 that you can think of?
From a clinical perspective, so
Yeah.
from a, I mean, there's many. I mean, medicines management, and you know, we've looked at, you know, emollient prescribing. We've looked at you know, things like over-the-counter medications. We've looked at, you know, the drug prescribing is often looked at for the low-value items. And then I think in England there are a list of low-value interventions as well, things like varicose veins that are not normally funded. So within our group we didn't, but we just picked on the breathlessness one.
Hugh has his hand raised.
I was just going to add in something that might have had an impact, but maybe not quite just yet. But actually, the reduction of the speed outside of schools in across Wales. So the impact of pollution on potentially asthma, and you know that's quite a it's quite a low value thing potentially, and if we were to be able to reduce the pollution levels within our cities, we might see a reduction in the number of people contracting, I suppose, pollution-related asthma.
Good.
Fantastic.
Okay.
Can you go to the second group?
Yep.
Yes.
Okay. I bet picking someone, will you? Okay, you got one.
I'll talk to our group. We haven't got any of the data like Helen. I feel a little bit trying to follow on from that is going to be a bit of a challenge. We had a bit of a discussion around what we thought would be maybe high value things. We thought that actually we know that you know, Wales has got the second most like overweight population in the world, I think, and it's over 60% of adults either overweight or obese. So we just thought that this is a real sort of opportunity for us here to be able to impact on something that has a massive impact on a number of different, I suppose, health conditions. So we thought if we were able to maybe address some of that in the local communities by giving greater opportunity and access to green spaces, exercise, and making food choices the healthy choice, the easier choice, like we talked about, the number of I suppose takeaway shops that are available for people to access food particularly in the most deprived areas is really high, and the actual quality of the food that's available often is difficult to be able to access locally. So thinking about things like how can we help those communities, the other things around obviously food banks and the stigma that's around using some of those in those areas. So how can we change the narrative around some of that as well to really support people within those communities? And that was some of the stuff that we talked about.
Were you able to identify any low value activities within the current kind of overweight obesity care pathways?
Sorry, can you say that again? And I didn't quite get it.
Were you able to identify any lower value activities in the current care pathways for people who are diagnosed as being overweight or obese in Wales? Or I don't know if you chose a specific health board.
We didn't choose a specific health board, but I suppose there are any number of activities that are potentially low value within lots of different, because obviously it impacts on a number of different health conditions. I don't know, does anybody else want to come in from my group on this? I suppose if we can turn around some of the people who would be deemed in that horrible term pre-diabetic, and we could help them to manage their condition before they graduate into full type 2 diabetes, then I suppose we could reduce the number of medications that are being prescribed for that. So I suppose that would be cost saving against some of that.
Yeah, good point. I remember we had one very good meeting. The renal community was very good. We were working with them in England, going back now, partly about the carbon footprint of renal services. But when Anna and I went to a meeting with the renal people, I think in the Midlands, and we said, what's your top priority? And they said prevention of type 2 diabetes, which is terrific from a clinical community like that, who are obviously under pressure for their dialysis. But their top priority was prevention of type 2 diabetes.
Do you guys have any issues with the semaglutide drug prescriptions?
Sorry, Anant, we've got a couple of hands up. Was your question related to who, or was it just a generic question?
It was just a general question about the care pathways, whether what is the current status of the semaglutides in Wales? What is the discussion on them? So you can go to the other hands first.
Fab. Kelly?
Yeah, I'm not a health professional, so I'm sorry, Hugh, I couldn't help you out just there. But one of the other things that we talked about in our group that I was with Hugh was how in social care, certainly, we get lots of grants to do things differently, but the way those grants are set up and when they're issued and the parameters around them make it really, really difficult for us often to do anything meaningful with them that we can then evidence to bring it into our kind of core budget, or to evidence that we've made sufficient impact for it to be worthy of bringing into our core work. And there's it feels to me like that's an issue in itself, that the way that finance and grants are kind of allocated from Welsh Government to social care, and I'm guessing this is similar for NHS, is by the nature of how they set up and the restrictions around them, and it means they're wasteful in themselves, because there must be lots of things, really good work going on with grants around the country that then local authorities or NHS cannot find the money for in core budget. So, you might set up something really. Yesterday, I was chatting to, is it Johan? I can't remember his name, in my group, about something that they did in his authority, and it's had a massive impact on well-being for staff, but they haven't got the core budget to be able to bring it forward. And it's really frustrating, because we need money to do some of these really, innovative things, but actually you can't then bring them in because you don't have the money to be able to carry them forward as your core business. And it feels very frustrating, and I feel like that's something that needs to be dealt with, because in itself that's wasteful.
Yes, yep. Yeah, I think it's getting a right sort of protocol and the right expectation for what's going to be done. I know these grants are often too short a time scale. Yeah. They make a big difference. So these grants, Kelly, they come from the government, do they?
We have every annually you get kind of grant money, and you have to use it for certain things. But by the time you get the money, then you have to employ the people, then you have to set up what you need to do. By the time we've done that, you're in 6 months down the line of a 12-month project.
Yes.
So, from what I've just spoken to Hugh about, that's something similar happens in the NHS, but it's wasteful, because there must be tons and tons of money being poured into projects, but there's not enough time to get them up and running. There's not enough time to evidence them. And then the end of that is you need the money in the local authority to be able to bring those projects in, and that's often hard because the extra money isn't available. So it does kind of stunt the growth of some of this prevention work that I think we need to, it's more around prevention, isn't it? The obesity thing, how do you prevent people getting to that stage? We have a massive issue with mental health for young people and children now. How do we stop that ending up in a crisis? The prevention services are not there because we don't invest in them enough. And I think that's a theme in social care. I'm not sure about the NHS, but it feels like it's similar.
Well, that's where we're starting to look at organisations that exist at the moment, like the football clubs for children, and look at them as communities. And that might be churches, mosques, start to think of existing communities and how we can build on them as opposed to developing new professional services, because they're very time consuming and expensive to do. But I can see the problems with the grant funding. There's a good rule, 6 months to get the grant up and running, and then you're closing it down.
Yeah.
Are these grants created by politicians? I mean, they have some bright idea.
Yeah, I mean, if you, Chris has just said in the chat, you know, it's kind of short-term political cycles. So
yes,
short-sighted solutions which don't change systems, which is essentially what we need to do to make any real change.
Yep. Good. We'll follow up the weight management pathway there. Yeah. Okay, good. Next group, Anant, I think. Like each other.
Five. Abby and team, how many?
There are 5 groups.
Okay, keep going.
So looking for someone from. Oh, there we go, Keris.
I'll start us off, but I'll need the support of my my other team members. So we looked at Swansea Bay, but just nominally, really. I don't think this particularly relates to a particular problem in Swansea Bay. I think it's generally everywhere. So we focused on falls prevention or admission due to a fall that is not related to an injury. So a fall at home that possibly could have been managed at home, but the patient is then it was pointed out that falls is within the top 3 reasons for conveyance to A&E in an ambulance. So of course you've got the ambulance cost, you've got potentially the wait time for the ambulance outside A&E if A&E can't accept the patient straight away. We have got then, once somebody's in A&E, the admin creation, the paperwork that Tim mentioned earlier, potentially, unless they've got very slick systems, digital systems, duplication of assessment as the patient is seen by different members of the A&E team. Potentially they then have that cascade of tests and investigations that may not be required at all. X-ray, bloods, potentially medications are prescribed because they're without their regular medication, and of course then there's the risk that they have an unnecessary stay because of the delays in the system. So we know that has a cost per night associated with it, and we sort of felt that there were a large number of these admissions that really could have been dealt with at home if people had the confidence to assess a fall as a non-injury fall at home.
Good. Has that been realised anywhere in Wales?
We didn't come up with many solutions.
Have we got our ambulance colleagues? Were they in that group?
I did have an ambulance colleague in that group.
Yeah, so recently we've been funded by Welsh Government to have a falls desk. So it's in the top 3 category of callers in Welsh Ambulance Service. So it's just an approximation between 70 and 90,000 fallers come through to WAST in a year. Starting from sort of looking at it from a sustainability and decarbonisation, sort of some of these are in rural areas, so the travel time to get quite prolonged. So sort of look at taking that aspect as well. So there's a wastage and cost where maybe if you had the prevention and education early on, then we could prevent the falls in the first place. But the other things associated with falls, because they're lower acuity calls, they could be on the system for up to sort of several hours. They obviously got a long lay, and then you've got the associated sort of problems, pressure sores, a bit of hypothermia maybe for the elderly that might have heating on in the winter. So they up going in when it could have been prevented early doors. So sort of then you have the extended wait at the front door because A&Es are full and they are sort of lower acuity still. And obviously the pressure sores and any sort of associated symptoms. And then when they go into A, then they must be likely to get a chest infection, MRSA, or maybe catch COVID, and the prolonged stay in hospital as well, deterioration within hospital. So there's looking at sort of how we can community aspect prevent in the fall in the first place. For my mind, it'd be sort of a lot of exercise and education, and sort of looking at building up sort of that sort of muscle mass, because as you obviously get older, you deteriorate with sort of your muscle mass, which you lose your strength and more likely to fall, trips and hazards. So sort of looking at that, the whole aspect of it from the front door. I don't know if you want to add anything. But
nothing else from me.
Yeah, you see, here we've got to think more broadly, and Anant will come on to this about the, I don't know what they're called in Wales now, the women's institutes, for example, the churches, the mosques, and my Live Longer Better system, we're certainly seeing strength as the part of fitness that's been most neglected. If I was speaking to you as a group of, speaking to your parents and grandparents, I'd be saying there's 5 S's in fitness: suppleness, skill, stamina and strength. And the 5th S is psychological. The room then groans about the benefits of activity. But I think we're now starting to look much more broadly. We're introducing activity prescriptions in England. And this would mean that the GP doesn't need to know anything or do anything, but an activity prescription, because we've got their postcode. Anyway, Anant?
Yeah, I mean, just reflecting on your experience, when you were discharged, you were given 0, this is post your hip surgery, 0 information on physical activity or diet. You were given 0 information on balance or strength training. And then I think in the 6 weeks after you were discharged, you had how many physiotherapy appointments?
2.
1, I think, if I remember. 2.
With a trainee physio, yep.
The trainee physio. I mean, this is just bonkers, right? So, you know, one of my clinical tutors, rheumatologist, I texted him and we started a WhatsApp thread after Muir had his, had his surgery, just to get a steer from him because he knows how to internally navigate. And I really like this guy. And, I asked about physio and all of this sort of stuff. And he's like, oh, no, don't worry. Those guys will sort it out. And his primary concern was the DEXA scans. And I think we're really, really missing a trick. He mentioned the DEXA scans like 2 or 3 times. And I asked about the physical activity like, twice. And he's like, no, don't worry. Those guys, they know what they're doing. They'll sort it out. And I mean, it really is, they have a fracture liaison service. They have capture the fracture. They want to prevent secondary fragility fractures. But their pathways are basically set up to, if Muir didn't take it on himself to buy his pedals that he, because he couldn't put weight on his hip, and to keep, the blood flowing to those muscles and exercising in a way that was non-weight bearing, I think you would be in a much, much worse situation right now, Muir,
yes,
in terms of your mobility. But they're very broken pathways and very lacking in common sense. Anyways, that's a brief rant, but did you guys identify any current lower value activities that could be disinvested from in the current care pathways for falls?
I think we felt that really the cascade of things that happened after that inappropriate admission really were all low value. None of them potentially were necessary. So blood tests, x-rays, things like that are highly likely after that admission.
And is there a pound sign that you might be able to put on that, even roughly?
We discussed the cost of an overnight stay in hospital, which, well, initially we went 750, but then we found a new figure of 350. Bloods, I know the cost of some bloods, but not all. Anyone else got any? Mwape was in my group.
Shall I come in? I've just looked
Lovely,
at
thanks,
the.
Mwape.
No problem, that's okay. So I've just looked at this and it says, obviously for avoidable A&E attendance for low impact falls, which is what we were looking at, there's significant, obviously, cost pressure. So we're looking at an ambulance cost, unnecessary ambulance cost of about 150 to 200 per patient. So by reducing even 1,000 of these unnecessary visits, that's an annual cost release of 150,000 to 200. And then for the non-elective hospital admissions following the falls, because obviously they may have that long stay in hospital unnecessary. So it's obviously due to lack of community alternatives, which we've talked about. So it's looking at around 1,500 to 3,000 per admission. I think this is taking into account everything else. We did discuss in the group that it's around, is it 300 a bed a day? But of course, this is taking into account all the other tests that are being run. So the costing of that. So a 10 to 15% reduction could be between 450,000 to 900,000 a year. And then the delayed discharge, which is a hidden cost, with the bed costing around 300. So even a small reduction, such as 400 bed days annually, would still save around 120,000 while still improving the patient flow. Finally, the most significant is the cost prevention harm. So like the hip fractures, which we've talked about, it costs around 25,000 per case. So preventing even 10 cases of these would release around 250,000, and that's not even including the wider social care costs. So obviously taken together, there's it represents a potential of around 1 to 1.5 million in the avoidable costs, which is very difficult to quantify, but they are there. I think if you take the time to sit down and write them. And of course, there's the key opportunities to redirect this spend upstream into prevention and early intervention, as well as community focused or based support, which we've talked about. So I think this will ensure better outcomes and also better value for money. I think there's also the reducing waste, which is not just about money, where we talked about time wastage and how much time could be saved. So patient time wastage, not just for the patient, but for the family and those related to the patient as well. So there's also those unquantifiable waste that cannot really be written down, but are significant. I hope that helps and gives a bit more, shades more light.
Yep. Just one little point, I do see in different parts of the country falls prevention programs, and then down the road there's a dementia prevention program, and further down the road in some other department there's a frailty program. But the risk factors are the same. That's why we set up Live Longer Better. We just got to get more older people, your parents and grandparents, weightlifting and dancing.
Just conscious of time, guys. I think we could feed back forever, but we've got an hour left for the rest of the session with another breakout room planned. Anant, do you want to do the next part and we can break out and incorporate a short break to come back then by about 25 past, ready for Muir to do his final session on the stewardship part?
Yes, very, very sensible. Thanks, Abby, for keeping us on track. Muir, are you able to share the slides again?
Yep, hang on.
Okay, cool. Next slide. Next slide. Right. So looking at social value and determinants, I mean, I think you guys are spot on with all of this stuff. So I'm going to go through this quite quickly. Next slide. So we know from a societal value or social value perspective that it's these determinants that are actually impacting people's opportunity to be healthy and well. So this is not the onus we don't put on the behavior, but actually the opportunity architecture for people to behave properly. So I think this goes back to one of the comments on the diet, make the healthy choice the easy choice. And here, you know, in this piece from Marmot, bad choices is put in quotation marks, precisely because many people don't actually have good choices in the environments that they're in. Next slide. Abby, I see your hand raised. Is that a legacy hand or is that a question or comment you have?
Nope, no, sorry, Anant.
Okay, no worries, no worries. So you saw the slide before. Clinical care, so access to doctors, you know, hospitals, nurses, pharmaceuticals, only accounts for about 20% of health outcomes. The other 80% are these determinants, again, which you guys are completely spot on and aware of. Next slide. And I think one of the key things, and again, what has been touched upon, perhaps not explicitly, but at least implicitly with the feedback that the groups have had and clearly in the discussions, is the notion of medicalization, in the sense that we're making medical problems out of things that aren't actually medical. That's that poster, the Medtronic poster that Muir showed on the toilets of the JR and in the elevator. It's waiting so long in terms of interventions and intervening for falls or for obesity or overweight, that it does become a medical problem. And if we intervened earlier, again, you guys get all of this, we'd be able to shift the curve. Next slide. And if we're looking at these determinants, I think we can broadly kind of disaggregate them into 5 subtypes: social determinants, digital determinants, commercial determinants, environmental determinants, and political determinants. None of these are mutually exclusive. They all interact with one another in sometimes predictable and sometimes unpredictable ways. So I have some examples and some references. If I just touch on some of them, unemployment increases all-cause mortality. So there you have social determinants and different types of social determinants impacting one another. Education has a dose-response relationship. So there's an average mortality risk reduction of about 2.9% for every additional year of education. 13 to 32% of global disease burden is attributed to environmental determinants. So there you have the environmental determinants impacting the social determinants. And 4 industries, tobacco, unhealthy food, fossil fuel, and alcohol, are responsible for over 30% of annual global deaths. So there you have the commercial determinants interacting with the social determinants. But oftentimes there's also going to be an interaction with the political determinants, because you have corporate capture, regulatory capture, which actually creates an enabling policy environment that allows these commercial entities to continue operating. Next slide. So this is the famous Jeffrey Rose curve. And when I said shifting the curve, this is kind of what we mean. If we look at the risk of the population getting severely sick, you have low risk, medium risk, high risk. And severe sickness would be a heart attack, stroke, hip fracture, death, diabetic retinopathy leading to blindness. And what Rose says is that most healthcare systems focus on the highest risk groups because of the highest risk. But if you look at aggregate morbidity, mortality, and spend, it's always in the bell of the bell-shaped curve. So if you look at that orange-yellow bell, it's always in the middle. And what Rose says that if you want to improve the health of the population, you have to focus on shifting the entire risk profile to the left. If you don't shift it to the left, the risk profile will continue drifting to the right. And as it drifts to the right, you have what Muir mentioned, the David Eddy kind of finding of the increase in the intensity and volume of clinical practice. We spend more money and we get less health in the population. This is what we see in terms of the real-time trends in England, at least. started off spending 110 billion pounds, and we've doubled it. And despite that, we still have a sicker population. Next slide. And these are some stark statistics. I think some of this was alluded to, but in Britain we have 4.5 million children living in relative poverty, and 1 million are destitute. And some of these families, we can't even get the basics right for these folks, right? This anecdotal example of one of these families existing just on cornflakes and rice. I mean, where have we come to where this is a situation that we're currently experiencing right now for such a large proportion of the population? Next slide. This is just looking at the opportunity architecture across these very basic domains: food, transportation, housing. I won't go through these in detail in the interest of time, but housing costs are increasing, transportation costs, and in Wales, I mean, this is definitely going to be an issue, right? Because you have the beautiful rural areas, but that also means that you need to drive to get to places. And now with the war in the Middle East, the fuel prices are increasing, which means that it's going to impact the other elements or aspects of a family's budget or an individual's budget. So the opportunity cost of spending on transportation means that they are, if they have a finite salary, not going to be able to spend on some of these other elements. Next slide. And this comes from Horst Rittel. So Horst Rittel was the guy who in 1973 with Weber wrote the seminal paper that first described wicked problems. And for these wicked problems and some of the things that you highlighted in your sessions from your group work are, I think, certainly classifiable as wicked problems. And what Rittel says is there's not solutions for this, but what you have is a resolution that needs to happen over and over again as contexts and situations change. Policy environment might change. You have the unpredictable consequences of the war in the Middle East. And what he says is that innovation is necessary to tackle this, but for innovation, Rittel's definition is not gadgets and gizmos, but rather innovation is defined as a social activity. Yes. So this is what you guys did in your groups. You came together as really great minds. And within that social environment of your small group work of 20 minutes, you're already able to come up with some fantastic ideas. And you already have in mind a predetermined purpose and a pattern expectation in terms of what you expect, for example, our care pathway to look like. And if we are able to have this defined more clearly, then you can get to and transition to what Muir would describe as a system, where you have a common set of objectives and a means of actually trying to achieve those objectives, and you measure it over time to see whether you're making progress. Next slide. It's interesting, one of the teams for the overweight mentioned the food banks. In England currently, there's 4,000 food banks in schools, and there's now more food banks in schools than outside of schools. And 45% of the senior teachers that responded to a survey said that they're supporting families financially, and teachers and support staff within the schools are actually stocking the food banks as well within the schools. Now, there is definitely going to be a stigma around the food banks. For me, this is sort of a signal of a societal failure. I think for the people that need the food banks, they should certainly be there. And I think it's just wonderful that the teachers are taking this upon themselves. But the fact that a situation exists where so many families have to be reliant on a food bank, for me, signals a societal failure. There's something seriously wrong with this. It is an innovation. It was a social activity because the schools came together to do this. They learned how to stock the shelves and set this up, and a system to kind of track and make sure that the people in the communities knew about it. But the fact that something like this is necessary is sad. But I'm glad that at least these guys have gone through the process of creating this as a resolution for the current short-term problem. Next slide. This is another business model. So just looking at allocations, this touches on my comment about the semaglutide drug. So just doing a kind of back of the envelope calculation for England. We have 15.6 million people who are obese in England, about 26% of the population. Wegovy and kind of similar semaglutide drugs. This price is coming down now. But back in the day, it was about 1,200 pounds per year. So if we gave every individual semaglutides, it would be about 18 billion pounds. And at the same time, we have about 12.7 million children in England. And if we use the same per capita cost that the London school meals had, which was 440 pounds per year, which could probably be brought down if you used economies of scale, that would cost about 5.6 billion pounds. And that reduces incidence of obesity. So not prevalence, but well, prevalence as well, but incidence, which is fantastic. It reduces stress on the parents because they know the kids are at least having a decent meal, and it actually improves reading comprehension for the kids as well. I take you back to that Lancet paper, which highlighted that we spent 75 billion pounds over a 20-year period. Now imagine over that 20-year period, if we just spent this 5 billion pounds or even 3 billion pounds or 4 billion pounds on these school meals, it would have had a much greater population level impact. And this is looking at reallocating resources and kind of spend avoidance in a sense, but then also reallocation to more strategic interventions that can deliver population health and help for the kind of left shift. Next slide. So now we come to the second batch of group work, which I think we're quite late on. So for the priority area, and I think we kind of already did this, so maybe we truncate this a little bit so we can get into Muir's kind of slides on culture change, but maybe we do 10 minutes where the groups come back together, or should we just keep it as an open discussion? Because I think there was already a lot of discussion on where some of the money could shift outside of the NHS to do primary and secondary prevention. I'm happy to go with kind of the group consensus. I don't know, Muir and Abby, what do you folks think? Should we do group work again, or should we just keep it as open discussion, or should we just go to Muir's kind of second bit about culture change?
I think people need to stand up a bit, Anant. We need to have a little break.
So what if we put everybody into the groups? The groups are ready to go, and bring everybody back at 1:30, and then go straight into Muir's.
Sounds super. Muir, are you okay with that?
Yeah, sure.
And they can do a working group.
Yeah,
well, star jumps and push-ups.
We just do a walking meeting. Walking is very, very good. Switch the camera off, and if you've got it on your phone. Anyway, don't worry about my obsession, but I'm going to take 5 minutes out of the pavement. Bye-bye. See you soon. So, Anant, what are we doing?
Just for clarity, we're going to put everybody into groups and bring everybody back just after 1:30.
Yep, fine.
Yeah, 1:30. Yep.
Let me know, guys, when you're ready to bring them back.
Yeah, I think we can bring them back, Bryn. I think if Muir and
Yep,
Anant are about
I'm back.
the plan, Anant, just to go straight into Muir's content, and if there is any questions, are you happy for us to collate them and send them over an email?
Yep, that sounds good.
Fab.
I guess just in the interest of time. That way we have, I think, a little bit of time at the end.
Yeah. So if
At the
Muir
end if
gets
people
his
have questions.
content out of the way, and then that should leave around 10 minutes at the end then.
Yep. Sounds
Happy with that, Bryn?
Sounds good to me. Yeah. So shall I wait until Muir returns to bring him back, or close the rooms now?
Wait for him to come back.
I'm here.
Oh, there we go. Okay, over to you, Abby.
Fabulous. Everybody back. Welcome back, everybody. Just in the conscious of time, we are going to dive straight into Muir's session on stewardship, and then we should have 10 minutes left at the end then to kind of wrap up any reflections. But if there's anything from your breakout sessions question wise, please send them over. And Anant said that he's happy that we can get them emailed over and get the conversation flowing if there is anything outstanding. So Muir, over to you when you're ready.
Thank you. Let me share the screen. So I'm going to speak about culture. And this is a standard pitch, and you'll get these PowerPoints and could use them anytime you wanted. Also, we're just publishing the second edition of our culture book called How to Create a Culture of Stewardship, specifically about stewardship, which I'll be discussing in the lecture. But that may be helpful to you. We'll try and get you a copy of the book to each of you. So, what is culture? Now, this is, again, the sort of talk I would give in a hospital or a health centre, but I'd give it in the town hall as well, for the public. So what is culture? And this is the idea. Now, of course, in Wales, where you have a much stronger idea of culture, because the idea of a Welsh culture is distinct from an English culture, but in the Midlands of England, culture's usually thought of something like this. This is a very simple model, organizational model, that an organization has three different elements: structure, systems, and culture. And usually we change the structure of the organization. I've had 20 structural reorganizations, most of which have made no difference at all. The leadership and management theorists would probably give structure 10% and culture and systems 90%. It's important, though, to remember, and I often use a quote attributed to Gandhi, that there's no structure can make bad people behave well, but the wrong structure can make good people behave badly. So you got to keep an eye on structure. But culture and systems, let's give them 90%, of which 50% would go to culture and less in systems, because unless there's a collaborative culture, systems won't work. Because there's many different aspects of culture. And I'm going to speak mostly about the culture of stewardship, but that's only one culture within the organization. Now, this is a guru, so you can quote this chap and no one will counter you. He's the #1 theorist on, he's a psychologist, and he's written very well on being a clinical psychologist too. But this is the single best definition from the single most important book on culture and leadership, Edgar Schein. And here's another couple of definitions which are sometimes useful for people to reflect on. So it's what stands behind and guides behavior. And it's the soft, fuzzy stuff. And then the end sentence in the Morgan and Leiker's quote is very important. Leadership and a company's culture are inextricably intertwined. And I've been very influenced by Toyota over the last 20 years. I'm sure there are other companies with very good cultures, but Toyota has been the most widely studied and reported. Now, this is from Cotter, who's another very highly respected management theorist. And I feel this is very important for you because you are on this course because you're part of a leadership program. And leadership and management are two different types of activity. Leadership is a set of processes that creates, it defines the culture. Leadership defines the culture. Management works within that culture. And again, back to Edgar Schein. That's probably the single best definition. So that's about culture. Now, how do we appraise culture? And there are three ways of doing this. Look at the artifacts, read the documents, and talk with informants. And this is what we mean by an artifact. The CEO's car parking is almost in the front hall of the hospital. You'd immediately notice that. No cycle racks, just the chief, reserved for the chief executive officer. And I'd like you now to start thinking about artifacts that you would be looking for if you went to look for a new job, or if you went to, particularly to do a project on stewardship. So there's general artifacts, but there's also stewardship artifacts we'll come back to. So how do you change the culture? Well, firstly, it's helpful to disrupt the culture, and that's why we produce Atlas of Variation, with a disrupt culture. And this is a key issue that takes place. And sometimes, of course, the culture is disrupted. This is what happened to Kodak, for example. But it's the issue of working in an environment where you need to change the culture. Secondly, introduce new language. And this is Benjamin Lee Whorf, the anthropologist, and he was one who created the culture of social relativity. That language creates new reality. So the more you talk about waste, the more you talk about value, and the different ways you talk about it, you're creating a new reality. So you need a common knowledge, a common language, and we've got a range of different resources. For example, we've summarized the 10 most important books in culture, and we have a culture glossary, which will circulate with as a result of this workshop. Because if you are, as the dragons, you are being developed as the leadership of the future. So culture is probably the single most important skill that you need to develop. So introduce new language. And here's another Toyota example, the word muda, waste. And there's another word, motai nai, I think I told you about, which is a feeling of remorse for having wasted resources. I don't see much of that in the NHS. Ban the old language, hub and spoke. I actually try and ban acute and community, because the hospital is surely a community service. Manager, I don't like the word manager. People who manage, because clinicians hate managers. But if we say to clinicians, well, you're managing too. So it's people who manage. Some manage full-time, some manage part-time. So I'm not saying that's the correct language to ban, but you change the language because that creates the new reality. Now, so number, disrupt, get the language right, training. And we've 5 modules that cover most of the things that we've been working with you on over the last few months. And we're very pleased to be linking up with one health board to try the online modules for that health board. And this is what I show when I'm speaking to a group of people in management and leadership and say, that's, you know, I see you looking at me from the audience, but here's what I'm thinking. I'm going to change it. We're going to change the wiring of the brain. It's a rewiring, new circuits, new language, new thinking. Then there's the developing an attractive way of communicating resources. And this is the way we will circulate this, an example of how to make a document interesting and structured and using pictures as well as words. Number 5, use images. And there's a very powerful image here to show people that these ants are all working together. The queen ant's not telling them what to do. It's not a bureaucracy. The queen ant's got a job to do, which is laying eggs. But all these ants are working, and the ants will probably see us off the planet. Now, when you're speaking to informants, and this is now to think about yourself, then here are the sort of difficult questions that you could ask. And I'm sure you've got your own list of questions for when you go to look for a job. But this is start to ask questions. So maybe ask you also to think about a key question about value. So just to summarize again, here's the one of Oliver Williamson. We're doing something that's too complex for markets or bureaucracies. Now, Williamson shared the Nobel Prize with this wonderful person called Elinor Ostrom. And the tragedy of the commons is when if everyone just acts in their own interest, first described in 1833 in Oxford, and if every shepherd just puts another sheep on every year, just to get a little bit more money out of the meadow, there comes a point where the meadow collapses. And that became called the tragedy of the commons. And this is her quote here. If those using the resources are allowed to manage those common pooled resources themselves, then sustainability is possible. They become stewards. You can't go in from outside or send in a consulting company. It has to be the people, the farmers, the fishermen, the clinicians who take responsibility for the stewardship of resources. And this is a key document which will also circulate. And I don't think I've met a clinician in England who's read it, but it's a very, very good and powerful document. And I'll just put this up for a moment. November 2014. Written by 2 young doctors, one of whom is a consultant surgeon, James Anstis, in Cardiff now. Very good. Look at that bottom paragraph. I say I've never met a clinician who's read this. So here's the tragedy of the commons, and here's the wonderful William Foster Lloyd, professor of political economy. He was a classics graduate. For each additional animal, a shepherd could receive additional benefits, but the whole group shared damage to the commons. If all shepherds made this individually rational economic decision, the commons can be depleted or destroyed to the detriment of all. So this is what the NHS is like at the moment. And this is what's happening. Here's the relentless rise of clinical practice. Now, we don't have time to look at this, but you'll be getting these slides. And so just start to think about this for your own health service. So a clear definition of resources. What's within our budget, and within our community, what other resources are there? How do we make decisions in our organization? Number 3. Number 4, how do we measure what's happening? And the farmers of Valencia have very clear ways of measuring water use, and they meet in the middle of Valencia every Wednesday. And there are sanctions for resource appropriators who violate the rules, agreed by the farmers, not agreed by the government or anything like that. This has been happening for hundreds of years. But the conflict resolution takes place. And self-determination of the community's resources. So, I'm not saying you adopt all of these, but I thought you'd like to see them. This is Eleanor Ostrom studying alpine meadows and water in southern Spain. And that's her classic book, The Government of the Complex Systems. So that's just an introduction to the concept of culture, and in particular, the culture of stewardship. And just like to take any questions or comments on that. One way to think about this is how you would introduce stewardship to your organization as part of developing value-based healthcare. Hugh.
Yeah, I just wanted to sort of touch on this point in that essentially a lot of our services are target driven, which causes really challenges or real challenges for us, because actually, you know, it's those targets then, and it's those staffing groups that shout the loudest saying we're not meeting these targets, therefore you need to be doing more in your areas in order for us to be able to meet these targets. So we need to be, and there's always that focus on this sort of like the firefighting, because that's where I guess the crisis is at that point, and we're really good at managing crisis in terms of what we do. Well, in getting it to a point where it's manageable. But what we're not able to do is during that, the voice that we need, which is what I'm hearing from you, is that the focus needs to be shifted to this earlier phase, but it gets drowned out by the fact that actually we've got these huge waiting times in A&E, so we need to be discharging people in a more timely way from the wards. And I guess that's the position we're in, is this kind of like ambivalent position where we know we need to make a change, but it's really tough.
Well, as you know,
I'm just wondering, how do we get to a stage where the culture of the organization isn't about these targets and trying to meet them around those, and we're actually investing in what we know? Because if you ask anybody, everybody knows that this is where we need to be heading for as a healthcare system, but it's how do we get people to take that leap of faith, I suppose.
Yeah, well, as you know, we don't have a system, and we have a set of structures, and targets there's something called targetology. Obsession with targets is very disruptive. One simple thing, Hugh, we could do, and I hold you responsible for doing this, is to get the name of A&E changed to SFS, System Failure Service. And another great Toyota thing is asking why 5 times. So when someone's lying in front of you in A&E, you ask why 5 times. Probing. That's another great Toyota technique. So we've got to create systems, population-based systems, and then move upstream. But I know the pressure that you're under for targets. Yep. Emily.
Yeah, I had something else, but then that was really interesting, and I think I'm always advocating for ED front door targets. Everything that we get from Welsh Government is improve performance in A&E, what you're going to do about it, what you're going to do in that system, and I'm constantly trying to advocate for those teams to say, actually, they're doing absolutely more and over and above what they can do. They can't impact on anything that is downstream from them, that actually, like, it is like you've just said, oh, I don't know what you just said then. It is like the fallout team that, like, you can't ever close those doors. But we don't ever see that direction around having similar targets. So they used to be called tier 1 targets, didn't they? And I'm a bit old school with ED. So we don't ever see those similar targets on the back door. So that's what I try to kind of push and change that language around. Okay, what about targets when patients are clinically optimized for discharge? How long does it take them to be discharged from there? We could have targets around those days lost, for instance, or days where patients, we call them red days, we aren't adding any value. We should have targets for that, and then we could see then what happens with ED performance. But I think that's way in the future, because all of the Welsh sprints that come from Welsh Government at the moment are still front door heavy. Even, you know, like a month ago, the discharge sprint. So yeah, it's all a bit bonkers. But my original thought was that there was a doctor that said to me around a lot of the challenge with the culture and that cognitive dissonance I find with our medical colleagues, is that everybody's really concerned with that patient and that risk, that culture of like risk aversion. But somebody said to me, like, they don't just take an oath to the patient, they take an oath to the system. And that's where I'm trying to lean in. So this all kind of really ties in nicely for me. So thank you.
Yeah, system, and standards rather than targets. You know, our aim is to help people who are deemed fit to go home, get 80% of them home within 48 hours, something like that. So you can compare performance between and learn from one another, not criticize one another. Yes, Helen.
Yeah, actually follows on really nicely from what Emily said. Because I think, you know, the stewardship part is not just for sort of clinical, you know, health and social care colleagues. It's also, I guess, how do we engage the public in that as well? You know, because I think I was just reflecting on one of the most important conversations I had. I'm a GP, and when I first started out, I was bringing a lot of patients back, which was satisfying my risk, but was probably not the best thing to do. And so I stopped doing that and used that sort of SOS PIFU model or whatever, you know, so that it was left with the patient. And therefore my you know, my time for the next routine consultation diminished, and it allowed other patients to come into those appointments. So that, I remember that being a really strong driver for me. And I know for sure that when I first started out as a clinician, I was doing a lot more blood tests than I do now, because I always think about what, you know, what is needed, what do I actually need, and what's superfluous. Because you kind of sometimes, you know, I know when I first started, I would just tick pretty much all the boxes, and now I think, actually, why am I doing that? Why am I doing that? Why am I doing that? So I guess, how do we get our sort of colleagues who are new to working in health or social care on the stewardship, within the stewardship culture? And then the other part of the question is, how do we engage with our patients, with our population, to make them understand why that's so important?
Well, chapter 10 in the stewardship book is called Citizens as Stewards. And I've argued in here with Paul Corrigan's support, he's a top advisor in England, that there should be, people should have a contract. Members of the public should have a contract with nothing written at all about rights and responsibilities. Then when it comes to reaching people, well, this is the role of leadership, but it may be projects. Projects have a part to play in doing that, but you've got to be absolutely clear you're out to change the way people think, who are their brains. Nick.
Yeah, I just wanted, you talked about threats to stewardship, or where does individualism come into it? I feel like that's the biggest threat. Like, it's not, there's no collectiveness, or there's a diminishing sort of collectiveness. It's all about me, my rights, my you know, yeah, my rights to be healthy or otherwise.
So that's very clearly, that's why I believe in the contractual approach.
Yeah.
That if you go, the farmers in Spain gather on a Wednesday morning and make sure the rules are being properly arranged. It's not the government who's doing it, it's the farmers. So Eleanor Ostrom is wonderful what she studied. And they wrote this down, it's hundreds of years down, how they managed Alpine meadows. And it may well be, I don't know about common land in Wales, but where you live, there'll be bits of the commons. So sometimes quite used to use local commons. I don't know what the Welsh is for commons. Anyone tell me what the Welsh is for commons? Let's have a look and see if there is a word for it. I'm sure there will be a word for it. Swapna, last point.
Thank you. Sorry, it was more of a thought, really. What about if what we are measuring is not really the right thing to be measured? So I'm a clinician, and length of stay is a term that kind of annoys me a lot because it's such a blanket term and it doesn't often reflect what actually is going on. But it's the metric that will get people sort of to sit up and listen. And in some ways, I feel it's not a very honest metric, if I have to be frank. And then that's just what I was thinking. So maybe are we measuring things that are easy to measure, or are we measuring them because they're easy to measure, but they don't really, bring about the change that we need?
Well, that's about the point about systems thinking. The first thing to do is to set the objective. For example, to minimize unnecessary muscle loss might be an objective. Minimize deconditioning. So that would be the measure of there would be a number of days spent in hospital. But that's not just taking duration of stay as the end in itself. The question is, what is the objective that we're trying to measure? And the using the word criteria, the measures we use for the objective. So in system development, the first thing you do is not just to choose some measure, but to set objectives. And again, we'll cover that with the resources we can send you.
Thank you.
So, yeah, last word from Emily.
Yeah, it's just relevant to what you were just saying. I was reading about the McNamara fallacy and what I normally find in terms of I see loads of data about what people are measuring to prove that they're doing a really good job. And I'm trying to look at things that are really hard to measure, but they don't always indicate, like, I don't know what you want them to. And it's like it's like easy to measure, hard to measure, what you can't measure, but is it important or not? And just because you can't measure it doesn't mean it doesn't exist. But I think that's what I'm struggling with at the moment, and trying to work against what I find as like a wall of people who just look at what we can measure and read what they want from it.
Yes. Yeah, no, the important thing is to there's a trade-off between the validity and the feasibility of measures. But the more valid a measure, the more expensive it is to collect. But you should stick out for measuring what's valid. Anant?
Yeah, just a quick comment. There's probably a lot of low-hanging fruit in terms of measures that could still be valuable. So, for example, what we find in England is that people with an initial diagnosis of type 2 diabetes, hypertension, obesity, overweight, or cardiovascular disease, a very, very small proportion of them actually get a referral to a physical activity intervention or a dietary intervention. Now, this is a very simple kind of binary yes/no measure, and it can almost immediately start to give you reveal some trends. You can see the number of people who had a fall that were referred to a balance class or an exercise class or a physiotherapist. So I agree that there are useless measures. There's also measures that are difficult, but there's also some easy kind of low-hanging fruit measures that will be process measures because they're not outcomes, but they at least give you an indication of where things are going. And then the other thing you can start looking at is population trends of incidence, for example, of preventable NCDs. So you look at incidence over time of type 2 diabetes, obesity, overweight, cardiovascular disease, anxiety and depression in children and youth. So these are all things that are fairly easy to measure. So I agree with the notion that there's a lot of useless stuff measured, but there's some simple things that we could use as kind of starting points or leverage points for figuring out what to do within the care pathways to improve them.
So yes, outcome is good to measure, but more expensive, and you may have to just choose a more feasible measure. The important thing, develop systems, set objectives, choose criteria, and even more important, create the right culture. And the culture we've been talking about is the culture of stewardship. It's not the only culture. We need a quality culture, a safety culture, no denying that. But the aim of our input in working with you is to create the culture of stewardship. So, Bryn and Abby, thank you very much, as always, for arranging this. Wonderful input from you all. And we know where you live, so we'll be in touch.
Muir and Anant, thank you so much again for coming and sharing your expertise. I could just see from the feedback and interaction of the group, they've really found this beneficial and an enjoyable session. I'll share the resource that you sent to gather some of that information from the group in regards to their case studies. I'll do that. I'll put a deadline and get that back to you as well, for you to have a little read. And if you could get some copies of them books, we'd be sure to distribute across the cohort too. So thank you so much.
Good. You're the future.
Thanks, everyone. Bye.
You're the future. And the job of you're the leadership of the future. And the main job of leadership is change the culture. Thank you very much. Bye-bye.
Thank you, Muir. Bye.
Thank you.
Bye,
Bye.
Anant.
Bye-bye.
Thank you.
Thank you.
Thank you.
Yeah. Hey guys, so what a morning.